Mama bear serotonin. No norepinephrine, 40 milligrams. Papa bear, 60 to 120. The three bears. Which bear do you want? You want an SSRI, give 20. You want a SSRI, you give 40. SSRI, you give 40. You want an SNRI, you have to have 60 to 120. So this is important because in the next lecture, which is coming up now after our questions, I am going to talk about using duloxetine not as an SSRI but as an SNRI. This assumes dosing of 120 or 90 or maybe 60, but more towards the high end. So the advantages of drugs in this class are dual action, maybe better efficacy. I think so in some patients, but it's controversial. There are higher reported remission rates, at least in some studies, and I think it's especially useful in refractory resistant patients. And we'll talk after the break about painful symptoms. Disadvantages, you have to titrate the dose because none of these drugs is perfect at just one dose. It doesn't bother me, but you have to mess around. Increase till you find the sweet spot. Adverse effects like nausea, hypertension, more with SNRIs. So it leads to the question, are two antidepressant mechanisms better than one? In the old days, we thought, no, tricyclic means dirty drug, means side effects. So we went to SSRIs. Better side effects, but maybe not better efficacy. Now we go back to dual action, but two therapeutic actions, either in one drug or in two drugs. So the rationale for the advantages of two pharmacological mechanisms over one is analogous with tuberculosis. If you treat people with one drug, they get treatment resistant. They get treatment resistant in a year. You treat with 3, they're well for 4 years. If you treat with 4, they're cured. AIDS, you treat with one drug, their CD4 counts goes down for a few months. You treat with 2, they live forever. That's called synergy. Why are we not using synergy in psychiatry? That's a whole other conversation. But there is the use of more and more mechanisms with more and more treatment resistance. Most of us would agree. It's based on the principle of pharmacological synergy. So I'm going to end with this evidence. Do you remember Craig Nelson from Yale? Down here is Nelson. He did this study with dizipramine, and you can see here he had green is partial response, red is no response, dark blue is red is response, dark blue is non-response. Here's Prozac, fluoxetine. There's some remission, but small amount. When you put them together, look at the blue. This is what your goal is, remission, right? Get backwards. This is dizipramine, NRI, norepinephrine reuptake inhibitor. Very low, bad outcome here. A little bit here. Put the two together. There. Because of that and similar ideas of adding atypical antipsychotics to SSRIs or adding other mechanisms like agomelatine, two mechanisms is better than one when you need more efficacy. In conclusion, different symptoms of depression are associated with specific regions of the brain. We had a minor neuroanatomy lesson. And when we come back from the break, I will play for you my rap song to get you in here. I will actually be singing with my staff the DLPFC rap song. Then, many depression-related areas of the brain are modulated by serotonin and norepinephrine. And you have tools to modulate those neurotransmitters to try to help to treat patients. If you don't have enough monoamine levels insufficient monoamine levels are thought to contribute to depression. Therefore, many antidepressants are aimed at increasing monoamines. And finally, dual-action antidepressants are thought, at least by some of us, to be superior to single-action antidepressants, at least in some patients and at least for some symptoms.